On Tuesday night, PBS and WGBY will bring you a Frontline program looking at being mortal. It's based on the book of that name by Dr. Atul Gawande, a surgeon in Boston. And Dr. Gawande basically looks particularly at the difficulties he sees many physicians facing when they deal with patients who are at the end of life, dealing with fatal illness and death. Here with us to talk about that now, Dr. Lewis Cohen. He's a psychiatrist at Baystate Medical Center. He has studied and written on end-of-life issues. And Dr. Sherry Taylor, a neurosurgeon, former Chief of Neurosurgery at Baystate Medical Center, and now affiliated with South Shore Hospital in the eastern part of the state. Thank you both for being with us. Dr. Taylor, I'll let you comment first on this. It seems to me you are trained to heal, to treat, to make better, not to deal with death. Is there a shortcoming there, do you think, in the very stages of medical training, perhaps?
I'm not sure that I'm going to answer it in the initial stages of medical training. It's the entire medical system from beginning to end. And I think you've encapsulated the most important question in your question. The entire system of medicine is set up to heal, to make people better. It's a process that starts from the moment the person hits the hospital or their doctor's office and moves forward in a very steady way to make people better. It's very hard to step back in the middle of that and say, are we doing the right thing? And so from my perspective, I think it's extraordinarily important that the person themselves and their family have these discussions and know how they feel about their own death and encountering it long before the situation occurs.
Dr. Cohen, I'm sure you want to comment on that, but let me ask you, doesn't a physician, and let me make clear if people don't realize, a psychiatrist, you are an MD. You go through full medical training before you then go into the specialization of psychiatry. Doesn't a physician want, and maybe really need, because of who you are and what you do, to believe there's something you can do to help, to simply go on every day treating people, dealing with families of patients who are or may be terminal? You want to believe there's something more you can do than say, let's prepare for the end that's coming.
Entirely true. And let me say, I'm the kind of psychiatrist that wears a white coat and spends my entire day with people who are medically and surgically hospitalized. So I see this sort of thing all the time. But the question really comes down to what is helping people. And what Dr. Taylor was bringing up, and I think it's a really quite wonderful point, the fact that she's a surgeon, that Dr. Gawande, who the program is going to be based upon, is a surgeon. These are doers. And they shaped a lot of medicine, which was a very action-oriented kind of thing. Let's do things, and it became, let's do as big a thing as we can, and then, this being America, let's do as expensive a thing as we can. And what I think has happened in medicine is, in some ways, a recognition that the oldest of physicians amongst us, the tradition was people would do things, but often they were more gentle, subtle things, and they might have an even more important impact, one that we sort of lost in the shuffle.
Mm-hmm. I'm sure you both want to comment more on that, but let me ask you, Dr. Taylor, I'll ask you to comment first. In the program, Dr. Gawande talks about his own father's fatal illness with cancer. And he said his father had pretty much come to terms with it. He had, and they had talked about it. And they saw a physician who seemed to have problems dealing with it and said to his patient, Dr. Gawande's father, he said, you could be back playing tennis this coming summer. The patient and his son/doctor knew that probably wasn't true. And yet, for the physician, it seemed to be important to say that or to offer that possibility. That's very hard to deal with sometimes.
Yes, it is. I think for many, many years, physicians were accused of having a God complex. One thing we really have learned as a group is that we really cannot always predict accurately how long a person's survival is. We can give people statistics, we can give people the odds, we can give people the likelihood of things, but there's always a few that are a surprise. So it gets very hard for the individual physician to say, I'm sorry, there's nothing else to do. So I understand that from a physician's point of view. At the same time, that's why this conversation has to take place. If the odds are so small, if the odds are so unlikely, and sometimes the treatment's so painful, that's the part we can't forget. That is a discussion that has to be had.
Doctor.
The odds could be so stacked in favor of that unlikelihood a person is going to live. But then we also know some other things about how they're likely to survive, what kind of quality of life they're likely to have. And we are unaccustomed to having conversations with, okay, this may save your life, but you do need to know that, again, the odds are such that you will never, you told me that it was important for you that you go out shopping with your wife and things like that. You're not actually going to be at home anymore. You're going to need to be institutionalized, or you're not going to be able to walk any further without wheelchairs or something like that to get you around. These are parts of what we leave out, what we physicians have, unfortunately, the last few decades left out in our conversations with patients, and it's part of what they and their families need to know to make informed decisions.
Dr. Cohen, let me ask you to comment first on this, and I think it follows from what you're saying, and please correct me or redirect me if you will, but it seems to me, we talk a lot about death with dignity, and I think people have an idea of what that means in terms of treatment, but it seems to me being as honest with the patient and their family as you can possibly be is also part of the respect and the dignity of taking someone into that final stage of life.
Yeah, I mean, death with dignity has now a specific term because that was tacked on, for instance, to the ballot initiative that we in this state of Massachusetts had a couple years ago to have a law similar to what they have in Oregon. What many of us have heard that Brittany Maynard, for instance, took advantage of. But putting that aside, although I'd love to talk about that, putting it aside, dignity does require something more than just this death piece, and it does involve informing people, respecting them, shared decision-making with them and their families, rather than imposing any kind of a opinion upon them that doesn't mesh with what their goals are, what they want.
Dr. Taylor, if I understood you correctly earlier, I think you were getting at the point that there are so many advances, so many amazing things in medicine today that you don't as often as maybe a physician a generation or two ago had to say, you don't as often have to say there's nothing we can do. Does that lead to then the difficulty of sometimes for a physician admitting to themselves and saying to a patient, we are at a stage where we have to think about how you want to take your treatment now through what I think is an inevitable end of life?
I think there are two parts to the question you just asked. The first part is the medical advances, and yes, it is true that there are many things we can do now that we couldn't do before. I really can't speak to some of the subtleties of cancer, but now many cancers are curable where they weren't before. Head injuries, which is something that I've been dealing with most of my life, really haven't had major advances in terms of the outcomes. So there are definitely certain parts of medicine where there have been huge advances. I think the issue of admitting things, I think most of us are willing to admit it, but sometimes the families don't respond well to what we're willing to admit. And so it becomes a very difficult conversation. And not only difficult in the sense that sometimes the families don't respond well to your wanting to have an honest conversation, but also it is emotionally draining to the physician. Imagine doing that day in and day out. I have to tell you, after 20 years, it really takes its toll.
Doctor?
And I'll say that one of the loveliest parts of what people will see in the Gawande film is going to be how he's come to the realization of the importance of the physician, the medical staff, listening to the patient, eliciting from them, from their families, what's important to them at this point in their lives. And then helping to shape decisions, providing them with information that's reflective of it. And he does that exceedingly well, and it's something that one hopes other people in the medical field will pay more attention to.
Well, Dr. Lewis Cohen, Dr. Sherry Taylor, thank you both for your time and your perspective on this issue.
Thank you for inviting us.